Welcome to the Frontier AETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, thanks everybody for coming today. We have a very exciting session. It's a pleasure to welcome Dr. Steve Johnson back to Echo. Dr. Johnson's done a couple of talks for us today, and he is going to tackle this question about archive or DNA genotypes, which has come up fairly frequently here during the session. So Steve, thank you for tackling this topic. For those of you who don't know, Dr. Johnson is professor of medicine in the Division of ID at the University of Colorado School of Medicine and director of their HIV/AIDS clinical program. And Steve, I will turn it over to you. Thank you.
Great, Brian. Thanks for having me. And we'll start this subject with a patient of mine, a 37-year-old male, HIV infection diagnosed in 96, CD4 nadir in the 400s, no prior opportunistic infections, of course. And he actually began antiretroviral therapy in August of 2006, as is frequently the case with some of these transfers, unsure of his specific regimens, but he recalls prior use of the medications depicted on this slide, including AZT, 3TC, tenofovir, DDI, lopinavir, nevirapine, and abacavir, and he transferred care to me in 2010. So his current regimen that was actually started at the other clinic is tenofovir FTC plus boosted atazanavir. And he presented to see me in follow-up in December of 2014. Laboratory tests at that time revealed a CD4 of 946 with an HIV viral load less than 20. And although he was tolerating this regimen quite well, he had had several friends that had switched to once-a-day regimens. So he expressed interest at that point in changing to a once-a-day regimen. He was unsure whether resistance tests had been done in the past, and attempts to get his records were unsuccessful. So the question here is, can he be safely switched to one of our single tablet regimens? And I think those of you that provide care for HIV understand that there are a number of situations now where we're looking to upgrade therapies, simplify therapies, use newer medications, and so on. And these are some of the reasons listed in the federal treatment guidelines, certainly reducing pill burden with an eye towards improving adherence, to enhance tolerability and reduce toxicity, to change food or fluid requirements. Some of you may not have had experience with Enfuvirtide or T20, but there was a period of time where we were using that medication in people who had drug resistance, and to be able to change off a parenteral medication like that was important. To minimize or address drug interaction concerns, so for example, ritonavir or cobicistat-mediated drug interactions, and a couple others listed here. Of course, there are reasons not to switch, and sometimes our patients cite these reasons for us. You know, if it's not broken, don't fix it. Don't get off a winning horse. This has saved my life, so why should I change? And I think, maybe earlier on in, maybe 5 or 10 years ago, we were quite a bit more reticent to make changes in individuals that had treatment success. But I think with the newer options that have been licensed recently, I think we have strategies to do this safely. Some patients want to save newer options for later, and insurance barriers can be an issue. And then, of course, when you change somebody to a newer regimen, even if it's statistically safer, that individual may have side effects. The other thing that's driving these switches, of course, is the increasing number of single tablet regimens. And of course, I list the ones that you're using that are currently approved, including the first TAF-containing compound that was licensed in November. We expect actually later this year the TAF version with FTC and rilpivirine, and probably in subsequent years the boosted protease inhibitor single tablet regimen. And of course, there are other kind of concoctions that people are thinking about and so on. But it really increases the number of options for this kind of one pill once a day approach. So I think many of you are aware that for some time now we've been able to do a tropism assay to assess for the use of Maraviroc in patients that have an undetectable HIV viral load. So instead of sending a plasma sample to do a tropism assay, we collect a whole blood sample and look within the white blood cells and do a DNA Tropism Assay. And this has allowed us to make switches in the past. I mentioned, for example, switching people off of T20, where a patient might have an undetectable viral load. We do a DNA Tropism Assay. The patient's virus uses CCR5, and we're able to substitute Maraviroc for T20. So we've had that technology for quite a while. More recently, we've had commercially available DNA genotyping tests, and the one that you're probably all familiar with assesses reverse transcriptase, protease, and the integrase genes. We actually here at University Hospital also have an in-house HIV DNA genotyping that just looks at reverse transcriptase and protease, and is probably reasonable for individuals who are integrase inhibitor naive. But the DNA genotyping evaluates for archived mutations in HIV Proviral DNA. I'm going to review some studies that show the correlation between archived DNA genotyping results and historical RNA genotypes done in plasma. And of course, this can be done in patients that have a low or undetectable viral load. And interestingly, this technology also holds promise for resource-limited settings where prior changes were done without HIV resistance tests. As I think you know, the WHO treatment guidelines typically start with a NNRTI-containing regimen. There typically is not baseline resistance testing. And then in the setting of clinical or virologic failure, there's a switch to a boosted protease inhibitor regimen, and that's also typically done without resistance testing. So this DNA genotype, if it can be cost reduced to a point where it's feasible, could be a way to kind of look back in resource-limited settings to determine what mutations actually happened that led to failure. Similarly, in some of our older patients that have had changes made in the mid-1990s and have been undetectable ever since, those are individuals who may have had changes made that predated our standard use of resistance tests. So here's a picture, of course, kind of depicting this. The standard resistance tests are assessing virus in plasma. For that reason, they need a certain amount of virus in the bloodstream just to be technically done. These standard resistance tests tend to pick the predominant strain. And so we've probably talked before about minority variants that may be missed, resistant isolates that exist in small numbers in the plasma. But what we're talking about today are DNA resistance tests. This is the integrated proviral DNA. So let's talk about a few studies that have looked at this. The first, and all of these are relatively recent studies, by the way. So this is a study in a community treatment program looking at 120 HIV positive patients. Some of the patients had detectable viral loads in their plasma, but 82 patients had undetectable HIV viral loads in the bloodstream and so had DNA samples only. But there was a comparison between the RNA and DNA genotypes, and where they could compare these studies, there was a concordance of about 84%. And so that's maybe the first point to make, is that there's not a perfect agreement sometimes between these DNA results and the RNA results. Of the 82 patients that had an undetectable viral load, actually 21 had drug resistance mutations to either 1, 2, or 3 antiretroviral classes. This is a different study looking at 169 patients from a clinical trial who had prior exposure to NRTIs, NNRTIs, and PIs. All had a viral load less than 400 at the time of the study. Historical genotypes, and there was a median of 4 per patient, were compared to the HIV-1 DNA genotyping. And you can see here in this last bullet the median number of mutations, RNA versus DNA. So 5 versus 4 for NRTI, 3 versus 1 for NNRTI, and 10 versus 8 for PI. And resistance to a drug was found exclusively in RNA in 63%, 47%, and 50% of patients, indicating, I think the major point from this is that DNA genotyping, although helpful, may not be fully sensitive. This is another study looking at a trial, the SPIRIT study. This was a trial switching suppressed patients on protease inhibitors to the fixed-dose combination of tenofovir, FTC, and rilpivirine. 81 samples were chosen to compare DNA testing with historical RNA genotypes. DNA genotyping was successful in 79% of these samples. And the bottom line is some additional mutations were actually found using the DNA assay. And the table on your right indicates a comparison between the DNA genotype and the RNA genotype. So in this study, there were additional mutations or perhaps enhanced sensitivity compared to the historical genotype. So I had mentioned actually the use of this in resource-limited settings, so I was intrigued when I came across this study. I was actually just in Zimbabwe for a couple weeks doing a visiting professorship, and this is a very recent study that was done there, looking at 125 whole blood samples from patients on first-line ART, and as mentioned, this is typically tenofovir 3TC with either nevirapine or efavirenz, usually efavirenz. and DNA was extracted from whole blood, so this is the DNA genotyping test. So 108 of the 125 samples were successfully analyzed, and actually 11 had drug resistance mutations, predominantly the M184V and the Y181C. And I think this illustrates some of the utility of this testing. You know, the 184V, of course, wouldn't be so surprising, but the Y181C, of course, would have different implications for sequencing with NNRTIs than if you had found the K103N mutation. So I think there are some potential issues with DNA genotyping. First of all, it may not detect all mutations that have occurred over time. Consequently, I think positive test results are more likely helpful than negative test results. We don't really know whether certain types of mutations are more robust and are more reliably found than others. And if the test is not fully sensitive, could ART changes actually lead to treatment failure? And then the opposite thing, if unexpected resistance to the current regimen is discovered by this test, does the current regimen need to be changed or intensified? In our limited experience here, we've had a number of cases where we've had somebody suppressed on a current regimen, and when we get our DNA genotype back, we're surprised to see resistance to some of the current medications. So this is actually the patient in question here, and this is his DNA genotyping results, and I have kind of blown up the results here on your right. So the M184V, of course, that we associate with 3TC and FTC, the T215, which is a nucleoside analog mutation. We used to call these TAMs, or thymidine analog, and you can see this can lead to AZT resistance. He has resistance to several of the NNRTIs because of his mutation at position 181. And then he also has resistance to nalfinavir and ritonavir because of the V82A mutation. So the conclusion from this case is that our DNA genotype actually detected significant NRTI, NNRTI, and PI mutations. And given these mutations, it wasn't clear to me that switching to a single tablet regimen with either an NNRTI or an integrase inhibitor as an anchor would be adequate. Some of you might disagree. You know, we think of dolutegravir as a pretty potent option that sometimes does not require a fully intact nucleoside backbone. But actually, because of these results, we elected to continue the current regimen and may considering an upcoming single tablet regimen that contains a boosted protease inhibitor. And the DNA genotypes that I've been involved with, this has happened to me several times where actually the DNA genotyping results actually prevented me from making a change. Now, you'll also notice that this patient was on tenofovir FTC and boosted atazanavir, and then there was a 184V mutation. So he's really on two effective drugs. I think you're probably aware that there are some data that boosted protease inhibitors are effective oftentimes in the presence of the M184V mutation. So I did not intensify his regimen, and additional drugs were not added. So I think the take-home points, first of all, because of recently licensed medications and single-tablet regimens, there are increasing numbers of really safe and simple treatment options. And so patients interested in switching medications is an increasing part of our clinical practice. Of course, these switches should be done only after a review of treatment history, prior resistance tests, issues with the current regimen, and pros and cons of the new regimen. And I think prior resistance tests are still important, even in the era of DNA genotyping. I think this DNA genotyping is a promising technique to help with HIV regimen changes in patients who are virologically suppressed. It has some limitations, as I've mentioned, but I'll also mention, of course, that our RNA genotypes have technical limitations as well. And with that, I'll stop and open it up for a discussion or questions.